Or here's the image if you wanted to start with that.
Did you mean the 3 o'clock or the 1 o'clock? Don't. Because she's wanting to come later in the day. Can I do 1 o'clock? She can do 1 o'clock. Hello? Can everyone hear me?
We sure can, yep.
Okay. I think are we starting here, Dr. Doyle?
Yeah, it'll be fine.
Okay. Dr. Doyle informed me I was doing this today, so ta-da! Happy Monday. Alrighty, so we have a coal miner here with, you know, sometimes we just follow what the state is going to test at the Occupational Lung Center. And so it's a basic spirometry with a diffusion study. Obviously, the gentleman has a normal spirometry and a decrease in diffusion.
Show me the case.
So go ahead and show us the case there. And that, I would like to also add, if you're familiar with your different reference sets, the state likes for us to use a reference value of Corey-Polgar. The data is the same, but the percentages are going to look a little bit different. So right now, this gentleman had his pulmonary function test on February 8th, 2021. He is a new patient to New River. Most of our coal miners coming in for their black lung, either to file or to be screened, are new patients to New River. 63-year-old white male with commercial health insurance. For our PFT values, okay, so we already have that. So what type of chest CT?
You questions last, but it's fine. The questions.
So I'm going to go down to the, if you could scroll down to the HPI, that'd be great for me. Patient is here today for evaluation of exertional dyspnea and follow-up on recent testing. He reports gradual progressive exertional dyspnea with dyspnea level of MMRC of 2. He still smokes 3 to 4 cigarettes a day, but formerly smoked 1 pack per day for at least 20 years. He has a history of 42 occupational dust exposure years as an underground coal miner. He currently drives 2 hours each way to work from Oak Hill to North Fork, to McDowell County. These guys are some of the hardest working people I've ever met in my life, just so y'all know. He works as a fire boss in low coal. He previously applied for OP benefits and received a total of 5% partial permanent disability in 1995. And that is when the state used to give awards based on a chest x-ray. They would give a 5% award based on chest x-rays. They've stopped doing that in 2004 and 5. And now it doesn't really, they give awards based on impairment in your breathing. Comorbidities, GERD, lipids, and, you know, relevant physical exam and lab results. He was alert, NAD, well hydrated, and slender.
She has to scroll down.
Go ahead and scroll down. Okay.
So that's the rest of the physical.
The rest of the physical is blood pressure is 120/60. His SAT is 95% on room air. Lungs clear to auscultation. Heart rate, regular rhythm. No murmur, no cabbage or stent. His extremities, no clubbing or edema. And neurologically, his speech is fluent and relevant. Stance and gait are normal. Chest x-ray, his occupational pneumoconiosis perfusion is 2/2. Complicated mass in the left upper lobe, right hilar fullness. Spirometry was normal with a diffusion of 69% of predicted, consistent with minimal reduction. His medications are naproxen, omeprazole, and rosuvastatin. And back up to the questions. Thank you, Mitra. So obviously they've found complicated fibrosis in his chest x-ray, or sorry, complicated pneumoconiosis in his chest x-ray. Always recommending a CT scan to rule out any type of malignancy. So the question for Allison was, what type of chest CT scan should be ordered in this case? What is the chance that the other B readers would not call this chest X-ray complicated? What are the different etiologies of fullness of right hilum and mediastinum? And Dan's going to jump in.
So thank you for that great, great presentation, Lisa. And I just want to say that this is a situation for people who work in the black lung clinics around the state and the country, and there's a number of us here today. This is a situation that very frequently arises, that we do these B-reader chest x-rays, and probably around 1 in 10, up to 2 in 10, come back being read as showing some kind of mass or suspicious lesion in the chest, and the radiologist says that they need a CT scan. And sometimes we feel as though, I mean, a number of us primary care providers feel like radiologists are always telling us to do more studies, kind of like one thing leads to another. But on the other hand, complicated pneumoconiosis really can look like sometimes malignancy. So it's very common for us to be seeing these kinds of reports. One of the things about this is that the minors have often been told this before 1 year ago, 2 years ago, 4 years ago. Some of them have pulmonologists. And so one of the first things we have to do is to check and see if there's a previous chest x-ray that showed this same thing or not. Is this a new thing or a stable thing? And also find out if they've already had a workup so that we don't do the same workup over and over. And some of them will speak up and say, wait a minute, my doctors already know about that. I already know about this. But some of them aren't sure, or some of them have never seen it before. So that was a reason why I really wanted to bring this case to the group. And our timing is perfect because Allison is talking to us about imaging. And I'll kind of leave it up to Elizabeth and Mitra and Allison whether we should have the group discuss these questions now or wait till Allison does her presentation, because her presentation exactly, well, among other things, addresses this situation. And in this particular case, I actually called Allison up and asked her, gee, what should I do? And she was very helpful.
Well, first and foremost, thank you all so much for that awesome case presentation. I'll leave that up to Dr. Seela's discretion. Dr. Seela, if you preferred going into your didactic now, and then we can certainly address these questions next time as well.
My didactic does not exactly cover this situation. It's more about the x-rays. I didn't have enough time to get into CT scans, so I mean, it's up to you guys what you want to do.
How about we go through a little bit of the questions, and then kind of around 8:20 we can jump right into the didactic. How does that sound, Dr. Seela, Dr. Doyle, Lisa?
That's fine.
All right, sounds good. So I'll just open it up to the group. If anyone have clarifying questions about the case or comments, thoughts you wanted to share, I can pull up the case again as well so you can see anything. Dr. Stansbury, thanks for joining. Great to have you.
Top of the morning. I don't know if you showed the actual images, but I missed the first part of the case.
We didn't.
We did not show the images.
Okay.
Next time.
All right, anyone else with recommendations, feedback regarding the questions? And I can pull up the questions as well. Feel free to unmute.
Actually, Caitlin, I know, Caitlin, that you have, Caitlin Grados, that you have a black lung program where you are. And Aaron, I'm not sure if you do or not. Maybe you could remind us. But I'm curious, you know, when you get a B-reader x-ray like this, what does your doctor do?
Hey, it's Caitlin. Most of the time, our doctor reviews it with the patient and then asks them if they have a history of this that they know of, and then we usually refer them for a CT scan or refer them back to maybe their own pulmonologist or their family doctor to take over from there.
Could you go up to the CT report, or did we have a report or no?
We had that PF.
Oh, chest X-ray.
Would you like me to pull that up again?
Oh no, that's okay. Let's see.
Mitra, did I send you the Dr. Stansbury? We don't have the actual image, and that is a chronic area for quality improvement of these presentations, because it's a few extra steps. Often we don't get it together, but I'm wondering, Mitra, if I sent you the actual X-ray report on this case. And we'll dig out. I think when I submitted this case, I didn't have the CT scan yet. We'll dig that CT scan out, so we can give you the actual report. If I can remember this guy's name.
I know, like,
No
I
more,
think
Dr. Doyle. I can email you after this, and we can work to have those images sent over.
Well, the hard work is on our end, unfortunately.
I think you called me, was it last Monday, Dr. Doyle? If that,
No,
I think it was
a couple weeks ago.
maybe 3 weeks ago then, because it was a week we didn't have conference and it was on a Monday. So that may help you to look at your schedule.
Yeah, we'll find it before this is over.
Before we move to the didactic, it's almost 8:20. Did anyone have any other questions, thoughts, or comments? Alrighty. Good, everyone. Dr. Doyle, we can revisit this case again next time we all meet as well, and by then we can probably put together that image and everything. So thank you so much for that case. Truly appreciate it. And thank Lisa as well. I think she's in the room somewhere over there. So, all right. Thank you. Dr. Sela, I'll pull up your didactic for you, and I'll just turn things over to you. Just let me know when you'd like to see the next slide.
Okay. All right, so it formatted a little bit differently. So forgive me if I pause when it goes from slide to slide. But again, my name is Allison Sela. I'm the Medical Director of Intensive Care and Cardiopulmonary Services at Mon Health Preston Memorial in Kingwood. Today we're going to talk about chest radiology, and we're mostly going to focus on the chest X-ray. You can go ahead to the next slide. So the goals of radiologic imaging is to recognize an abnormality, to be able to tell a variation from what is normal, to characterize that abnormality and to localize that abnormality. And here you see an early chest X-ray. Next slide. So the questions that we ask ourselves when we're looking at an X-ray, is it acceptable? We're looking to see the anatomy. You want to be able to differentiate the lobes and the fissures, the mediastinal structures, the airways, vasculature. You're looking for different types of signs that may give you a clue as to some pathology that may be going on. You want to look and see if there's any lines, tubes, or drains, and then ultimately to see if there's any type of abnormality or disease in the X-ray. Next slide. So these are our goals for today's topic, or today's talk. We want to understand the difference between the different types of views, understand the terms inspiration, penetration, and rotation, learn the basic anatomy of the fissures of the lungs, the heart borders, the bronchi, the vasculature that can be seen on a chest X-ray, learn the concept of atelectasis and the ability to recognize it, appreciate pulmonary edema on a chest X-ray, appreciate the different findings of atelectasis and pneumonia, recognize pleural effusions and pneumothorax, and recognize a pulmonary nodule. Next slide. So this is a PA view. And you can see that the patient's chest is up against the cassette, and they're shooting from her back through the front. And this is what the appearance looks like in the x-ray on the right. Next slide. And this is positioning for a lateral view. Again, the patient's side is to the cassette, and they're shooting from the right side to the left side. Arms are up out of the way so that they don't block the lung fields. You can imagine if her limbs were at her side, that you would be looking through an arm into the chest, through another arm before you get to the cassette. So it's important to get the arms up and out of the way. Next slide. So with a normal PA chest x-ray, these are some of the landmarks that you're looking at. You can see, I don't think my pointer would work, but everything is labeled here. The spinal processes, you can see the clavicles up at the top, the scapula over to the sides. We're looking at anterior ribs, which sort of curve inward, and posterior ribs. We can see airways, we can see vasculature such as the aortic knob, the descending aorta. Down at the bottom, we can see the diaphragm, the liver. We can see on the, when you're looking at the screen on the right side of the screen, we can see the gastric air bubble. Remember, this is like the person is standing in front of you and you're looking at their chest. So everything is going to be switched. The stomach, when you're looking at it, is on the right side. Obviously, it's on the patient's left side. Next slide. So we're going to talk about the term inspiration. So when you get a chest x-ray, the patient should be examined in full inspiration. So they should take a deep breath in and hold it. And this helps us to determine if there's any intrapulmonary abnormalities. When you get a full inspiration breath, the diaphragm should be at about the level of the 8th to 10th posterior rib or the 5th to 6th anterior rib. And that is considered a good inspiration. You can see this x-ray demonstrates that. Next slide. This is the reason why you want to get a good inspiration. If the x-ray is taken during expiration, on the film on the left, you can't see the side of the right heart border. It looks like there may be a pneumonia down there. So if you repeat it with a good inspiration, you can see the x-ray on the right. This is the same patient, and you can see the clearly defined heart border there. So again, a reason for you to get a good inspiration. Otherwise, you may misdiagnose the patient with a pneumonia or some other type of finding. Next slide. The next term we're going to talk about is penetration. And so that has to do with exposure of the x-ray. So what you want to see, the thoracic spine disc spaces should barely be visible through the heart. Bony details of the spine are not usually seen, but you can usually see the bronchovascular structures through the heart. And so you can see that on the first, the x-ray on the top is a PA view, and then on the lateral view, the spine should darken as you move towards the head. And you can see that it's very gray, and then it gets much whiter as you go up towards the head. And you should be able to see the sternum on the lateral view as well. And the sternum is the bright white bone in the front of the chest there. Directly behind it, there's a small gray space, and that's where you get into the lungs. Next slide. This is a picture of a underpenetrated film on the left and an overpenetrated film on the right. So you can tell on the left, you can't see any of the spinal processes, you can't see any of the vasculature in the heart. And on the right, you can see everything. You can see those spinal processes all the way down to the diaphragm. And you can tell that there's no way you'd be able to pick up any abnormalities in either of these films. Everything on the left looks a little white. Could that be a pneumonia? And there's absolutely nothing that you can see with any type of detail on the image on the right. Next slide. Next, we'll talk about rotation. So you want to keep the patient's chest or side flat against the cassette. If the patient's rotated, the mediastinum may have some sort of different appearance. You may think there's, again, a pneumonia or some other type of pathology that's not really there. And one of the best ways to look and see if this is a good film for rotation is to look at the clavicular heads. And you can see, sorry, this is really hard without a pointer. You can see that the clavicles are the two bones that come across from the top of the shoulders down to the midline, and they should look equal. Next slide. This is an example of them not looking equal. The patient is rotated, and you can see on the left, the clavicle goes up and off of the screen at the top, and the right, on the x-ray, the clavicle comes straight across. And you can tell by looking at this x-ray, there's this giant blob in what would be the patient's right chest. And that's because they're rotated, and all of those structures from the chest are appearing to be in their right lung instead of in their normal position. Next slide. So again, the objective of a chest x-ray is to detect an abnormality and to describe it as clearly as possible so that the differential diagnosis can be determined. Both of these images demonstrate a left upper lobe abnormality. And so in this instance, the x-ray on the top would be read as a well-defined mass versus the x-ray on the bottom would be defined as a poorly defined opacity. And you can tell the difference. You see clear borders in the image on the top versus on the image on the bottom. You can tell that there's something going on there, but there's no clear borders. So it's poorly defined. Next slide. Next, you want to describe the location. So masses in the chest can have 3 different locations in the thoracic cavity. The first one is intraparenchymal, and that is letter A on the image, and that is something that is within the lung proper. B is pleural, so it's in that pleural lining or pleural space, and then C is extrapleural, which is outside of the pleural space. Next slide. The image on the left is a pleural-based mass. The image on the right is an extrapleural mass, and you can see that it's sort of pushing in on the pleural lining there to give that appearance, versus the one on the left is actually coming from the pleura. Next slide. So the lungs are divided up into different lobes. On the right, we have the upper, middle, and lower lobes, and on the left, we have the upper and lower lobes. These lobes are separated by fissures, the oblique fissure and the minor or the horizontal fissure. Next slide. A fissure is a groove. Again, it's seen on x-rays, and all it does is separate the lobes of the lungs. The transverse fissure divides the right middle lobe from the right upper lobe, and the oblique or major fissure divides the right lower lobe from the right middle and upper lobe. It also divides the left lower lobe from the left upper lobe. Next slide. So this is a frontal view of the lobes of the lung. The 2 curved lines at the top of the x-ray outline the superior border of the oblique fissures. The horizontal line is the minor fissure, and then the curved line at the bottom is the inferior border of the oblique fissure. Next slide. I think it's a little bit easier to see on the lateral view. You can see the oblique fissures on both sides. The left side of the screen shows the right lung with the oblique fissure and the minor fissure. You've got the right upper lobe above both lines. The right middle lobe is towards the front, where that arrow saying minor fissure is pointing, and then the right lower lobe is below the oblique fissure. And then on the image on the right is the left lung. Above the line is the left upper lobe. Below the line is the lower lobe, left lower lobe. Next slide. And here you see the right middle lobe outlined on both the frontal and the lateral views. And so by knowing your fissures, being able to locate your fissures and knowing the anatomy that falls within those lines can really help to determine pathology. Next slide. This image shows fluid in the fissure. So again, remember that slide a couple slides ago that had the red lines in it. And you can see in the image on the left that there is a horizontal line of white going across the lung, and that is fluid in the fissure. And you can see the same finding on the image on the right. You can see that horizontal line that is a little bit more prominent, and then you can also see the oblique fissure that's more prominent there. This patient also appears to have a heart valve, which you can see that circle right in the middle of the chest. Next slide. This is the CT view of fluid in the fissure. Right along those red arrows shows the fissure. It's a little bit more prominent with that gray line of fluid that's running through there. Next line. And this is a pathology picture of the lung that shows the fissures. Next slide. Here's an anatomical drawing which gives the vasculature. You can see this large bundle of vasculature in the center with arteries, veins, and lymphatics, and that corresponds to the oval on the right picture, which is a bundle of vasculature and lymphatics there. Next slide. Again, you see this just from the other view. Next slide. Okay, now I said, you know, knowing where the fissures and knowing where the lobes fall is important in determining pathology and diagnoses. And so you can see here on the image on the left, that right middle lobe area looks a little bit darker than the rest of the lung. And you can see it a little bit more clearly in the lateral view, that there is a nice white shadow in the area of the right middle lobe. And this, in fact, is an X-ray with a right middle lobe pneumonia. Next slide. So this X-ray, or this particular image, shows the mediastinal structures. It shows some of the veins, the superior vena cava, the aorta, the diaphragm, the borders of the heart. You can see the right atrium and the left ventricle are outlined there. Next slide. This slide shows the lung borders. And so again, using the fissures and the lobes from the last couple of images that we had looked at, you can sort of place the lungs here, and you can tell where the border of the right upper lobe, the left upper lobe, the right middle lobe. And so again, that becomes important when you're talking about pathology and diagnoses. Next slide. This slide gives an outline of the main airways. You can see the trachea, which terminates with the carina, and then it branches into the right mainstem bronchus and the left mainstem bronchus. The right mainstem bronchus immediately branches off as well. Next slide. Again, the carina is just below the aortic arch. The right mainstem bronchus divides in the mediastinum into the upper lobe, which is the highest or the first takeoff, and then the bronchus intermedius, which will then further divide into the middle and the lower lobes. The left main bronchus divides into the upper lobe, which also supplies the lingula, and then the lower lobe. On this X-ray, the red circle is the aortic arch, I know it's drawn in here clearly with fluorescent colors, but you can actually see these structures if you look at enough chest X-rays. Next slide. Again, this is the same type of image that we just looked at with the trachea. Number 2 on this shows the azygos vein. 3 is the right mainstem bronchus, 6 is the left mainstem bronchus, and then 9 shows the carina. A is the aortic arch again. Next slide. This is just a nice diagram of the airways. So you sort of, you know, can picture this and place this on your chest X-ray and know which area you're looking at. Next slide. Pulmonary vasculature in those same areas. Next slide. And this gives an overlay of the airways in gray and then the vasculature in white. And you can see all of the important structures that lie very closely to other important structures. And so sometimes an x-ray is not enough, and sometimes you do need to move on to the CT scan to get a little bit better idea of what's going on. And getting back to the case presentation, that was one of the things that Dr. Doyle and I spoke about, is with his patient with having some right hilar fullness. It's hard to differentiate whether this is an airway issue or a vascular issue, and contrast will sometimes help to differentiate that. But that's probably in more detail than we'll talk about today. So let's move on to the next slide. This is some CT images that show, I'm sorry, it's really blurry on my screen. Hopefully it's a little bit clearer on yours. The image on the left shows the left pulmonary artery. The image on the right shows the right pulmonary artery, and how they sort of go right in through the lung and the other structures in that mediastinum. Next slide. So next we'll talk about the silhouette sign. And so what the silhouette sign is it's a loss of a normal border between structures. And so when you're examining the fields of a normal chest x-ray, the silhouettes of the heart border, the ascending and the descending aorta, and the aortic knob and the hemidiaphragms should all be clear. You should have a nice border, a nice outline along those structures. If you lose any of those borders, there is probably an abnormal processor that's causing that loss. So if you lose the silhouette along the right upper heart border or the ascending aorta, again, that abuts the upper part, or the anterior part of the right upper lobe. And so if there is a loss of that shadow, you want to think of some type of right upper lobe disease. If you lose the right heart border, you're talking about the right middle lobe, and we've already seen that in an x-ray. If you lose the left upper heart border, you're concerned about disease process in the anterior segment of the left upper lobe. If you lose the left heart border, you want to think about a lingular disease process. The aortic knob is the apical portion of the left upper lobe, and then the anterior hemidiaphragms are the lower lobes, either on the left or on the right. Next slide. And so this is what I was just describing. And so the image on the left, the gray structures are those areas where you're silhouetted. So you've got the, like the right heart border abutting the right middle lobe. Along the diaphragms, those are the lower lobes. And so if you lose that, if those areas that are gray on this image become sort of blurry or out of focus or white in those areas, that's probably the lung part of the lung that you're having the disease process in. And so this is demonstrated clearly in the image on the right. You can see that you lose that right heart border, and so that abuts the right middle lobe, and so this is a right middle lobe process, and you can see that this is clearly a right middle lobe pneumonia here. Next slide. Next is an air bronchogram. And so what an air bronchogram is it's a tubular outline of an airway that's made visible by the presence of a fluid or infiltrate around the airway. And so we can see this if you've got a lung consolidation, which can happen in a tumor. It can happen in a pneumonia. If you've got pulmonary edema or atelectasis, if you've got severe interstitial disease, and then also with normal expiration films, you can sometimes see air bronchograms as well. And so probably one of the better pictures is this picture on the right with the red arrows, and it's outlining an airway. And you can see the a little bit darker shadow of the gray airway there, and that's because there is some type of fluid or consolidation around that airway, but the airway remains clear. And so again, when you shoot an X-ray, air is going to look gray, and so you can see that there's air in that airway with some sort of disease process around it, and so that airway shows up a little bit clearer. In the picture on the bottom below that, you can see the airways, which is showing up in black or the dark gray, and it branches, and then all around it is this white consolidated lung, which is probably a tumor. Next slide. Here are some other pictures of air bronchograms. In the image on the left, you can see these sort of dark gray circles that show up intermittently throughout the whole lung field. And then on the right, you can see some of the same images that look more more circular. The ones on the left look a little bit more oval or oblong, like they're following the length of the airways, versus the ones on the right, you're sort of seeing the airway on end, so it shows up like a circle. Next slide. So moving on to lines, tubes, and drains. Some of the lines that we can see on images, we can see an IJ triple lumen, you can see a subclavian triple lumen, a PICC line, a tunneled catheter, a port. One that I forgot that my husband pointed out when I was having him review this presentation for me is a swan, which we don't see a lot of anymore, but can also be seen. Tubes, we're looking for an endotracheal tube, a tracheostomy, an NG tube, and then drains, we see pigtails and we see large bore chest tubes. Next slide. So this image is a right IJ. So again, remember when you're looking at these images, it's like the patient is standing in front of you. And so what you're seeing on the right side of your screen is actually the patient's left. So when we're looking for a right internal jugular vein catheter, we're looking on the left side of your screen, and you can see that there is a bright white line that comes from the top of the screen, and it goes down right along the side of the heart, and it stops right about where that mess of wires is, and that is your right IJ catheter. Next slide. Here is a left, and so this is going to come from the opposite side. It's going to cross the middle of the body, and it's going to end about the same place that the last one did. And you can sort of see it coming across from the top of the screen down through the shoulder, and it crosses the midline. I'm really sorry. I didn't even think about not being able to use my arrow when I put this presentation together, so I apologize. Next slide. This is a subclavian, and it is on the left. Oh, thank you. Can you guys see my arrow?
We can.
Or no?
I did give you remote control, so I wanted to kind of test that out and see if you can kind of navigate it on your end too.
Are you seeing my arrow move?
No. Does anyone else see any arrow?
It's up
I think I see
left
it,
of the
but it's not
screen.
moving.
Okay, it's not moving. Okay. You know what, Mithra, can I share my screen?
Absolutely, yes. We can
Okay.
do that. Let me stop sharing my screen.
This is going to be a lot easier. And I can go back and go over any other images that you guys would like to see as well. Okay, are you seeing my, whoops.
We do not see your screen, no.
Hold on. Okay, how about now?
Yes, we can definitely see that. Awesome. Thank you, Dr. Seela.
Okay, this will be a little bit easier. And you can see my arrow?
Yes, we can.
Okay, perfect. Okay, so right IJ, it's coming from up here, and it's coming down, and it's terminating right about here. This is the left IJ. It's coming from the opposite side, from the neck. It's coming down across the midline, and it's terminating right about here. Next is a subclavian, and so this is going to be positioned instead of in the internal jugular in the subclavian vein, and so it is hard to see on this overpenetrated x-ray, but it's coming from here, and it terminates right here at the arrowhead. This is a PICC line. So a PICC line is a peripherally inserted central catheter. So it's inserted in the arm, and it comes across, and it is over here, and it comes across. And then this is a tunneled catheter, and that's what this line is here. This is the port, and it comes down, and it terminates here. And you can see this is a larger bore. It's got a larger diameter, possibly a temporary dialysis catheter. This is a port that you would use for chemotherapy, and you can see the ports are, they generally have triangular shaped heads, although that may be changing, but this is the triangular shaped head, and you can see that the port goes over through here. Now this port is accessed, so they've got a needle in the port, and you can see that's what this sharp white line is, and it goes right into the center of this port, so they're accessing it and using it at this time. So next we'll move on to tubes. So an endotracheal tube, and you can see this is an endotracheal tube. It has these white lines in it, so you can see the outline of it, and it goes down and it stops right about here. And again, in this person, you can see their airway, so their trachea is outlined by the endotracheal tube, but you can see the carina where their airways sort of branch off here into the right and left lung. This person, unfortunately, their tube was pushed down too far, and so you can see this white stripe of the endotracheal tube, and instead of stopping where you'd want to stop right about here, it went down into the right mainstem. And so our right lung looks great, it's being fully ventilated. Our left lung is being obstructed, and you can see the difference of that on the chest x-ray. This person has a tracheostomy. That's what this black hole is here, and there's a short tube that goes down to about here. Next, we'll move on to nasogastric tubes, NG tubes. So these are put in through, nasogastric is going to be through the nose, orogastric would be through the mouth, and they go down through the esophagus into the stomach, and you can see, my arrow, you can see that termination. It's a little bit hard to tell, but it's somewhere behind this EKG lead. This person, instead of going down through their esophagus, went down through their trachea, and you can see it follows the outline of the airway here and right into their right lung. And you can see, again, the airway, you can see the outline of the trachea here, the carina here, going into the left lung and going into the right lung. A pigtail catheter is named a pigtail catheter because it looks like a pig's tail. It's curly on the end. This is a small chest tube that helps to drain fluid. You can see it here, and it curls around at the end. This is a large bore chest tube, so it's got a larger opening at the end. It is straight. It has this radiolucent line going through it. This break in that radiolucent line is a hole for drainage. Because these are larger bore, they can help to drain not only liquids, but stuff that might be a little bit thicker, pus and infection and things like that. So, our chest x-rays help us to determine pathology, what types of processes are going on in the lungs. And I'm not going to read through this. These slides will all be available, but these are just some of the different things that we can see on chest x-ray. Excuse me. So we'll start with atelectasis. So atelectasis is collapse or an incomplete expansion of the lung. It's a common finding. It can be caused by any type of lesion, such as a mucus plug or a tumor in the lung. It can be caused by some type of extrinsic compression, either from a lymph node, compression from fluid. It can be rounded atelectasis, which is usually seen after some type of prior inflammation. But what we see in these instances is a density in the lung and a volume loss. And you can see down here, we've got a little bit of atelectasis at the bases. You've got some atelectasis here and over here as well, possibly from fluid, because you can sort of see the outline of the fissure here. And here you see the right middle lobe again with some atelectasis, and there's some atelectasis here at the base. This image shows some left upper lobe atelectasis. And so the next series of images we're going to follow this type of setting here. So this right here is a frontal view of both lungs, the right lung and the left lung, and then this is the lateral view. And then we've got x-rays that show you, in real time what this looks like. And so you can see here, we've got some sort of shadow going on. You've got some atelectasis here in the left upper lobe. Over here, you've got something going on in the left upper lobe as well. And then when you look at the lateral view, you can see that it sort of follows follows that typical shape. Here's left lower lobe. And again, what you're going to see is right along this, this border here and along the diaphragm. In the lateral view, you'll see it in the posterior aspect in this lower corner. And so here you can see right along here, there's this abnormal shadow, and this is some atelectasis. You see it again here. And then this is the same person with resolution. You can clearly see this definition of the diaphragm here and the heart border here. Right upper lobe atelectasis, you see this sort of wedge-shaped area at the top of the right lung. And with that, the transverse fissure lifts up. You can see that is what these arrows are demonstrating here. You can, in this diagram here, it's pulling up this way and pulling up that way. Right middle lobe, I think the right middle lobe is the easiest to see these instances demonstrated, and so there's quite a few pictures of that. But you can see this area here, if there's atelectasis, this shifts down and this shifts up. Same here, this fissure will shift down, this fissure will shift over, and you can see this sort of band right here and this wedge-shaped infarct here. Right lower lobe is all along the right heart border. Here you lose. And you can see here that it's not real clear. It's sort of a curved shape, and so there's some sort of process going on here in the right middle, or I'm sorry, right lower lobe. This picture shows pulmonary edema. There's increased pulmonary vasculature and an increased heart size, probably a congestive heart failure patient. You can see their heart extends over here and extends over to here, so their heart is a little bit bigger. And you can see all this sort of white stuff going on here. And you may think that this is an underpenetrated film, but again, if you check, you can see your spinal structures, and so this is more likely to be pulmonary edema. It often appears in a bat wing appearance, and that's what we're sort of seeing here. There's fluid all through the lungs here. You really lose a lot of that outline of the heart. Two more pictures of pulmonary edema. With congestive heart failure, these patients are going to show cardiomegaly, so their heart's going to be enlarged. They're going to have alveolar or pulmonary edema. They're going to have increased vascular markings, and that's what we saw in these previous pictures. So with pneumonia, you can see aerospace disease and consolidation. You can see a lobar consolidation. You can see interstitial opacities. These are space-occupying lesions, so there's some sort of abnormality there, but you don't lose volume on that side. Occasionally, or oftentimes, you can see an effusion associated with the pneumonia. And then the presentation and how they look on chest x-ray can help to determine the likely cause. There are some pneumonias that are more likely to be lobar, which is pneumococcal. It involves the entire lobe, and there's often air bronchograms seen. Staphylococcus is more likely to be a lobular pneumonia. It's patchy, it's multifocal. Sometimes you don't see any air bronchograms. If it's an interstitial process, so it's not confined to one lobe, then that tends to be a viral or a mycoplasma type of pneumonia. Aspiration pneumonias follow gravity. If you are eating and something goes down into your lungs, it's going to go all the way down to the bottom, and so you tend to see things along the bases. Because of the anatomy of the airways, the right base is usually more common. And then diffuse pulmonary infections tend to be community-acquired mycoplasma, nosocomial like Pseudomonas, or ventilator-associated pneumonias. And then in immunocompromised patients, it can be fungal or PJP. So these are films of a right middle lobe pneumonia. There is indistinct borders. There's air bronchograms, silhouetting of the right heart border. So again, you've lost this right heart border, which should be somewhere around there, but it's not a clear sign. So you've lost that silhouette sign. So you know that the right middle lobe abuts the right heart border. And so there's a process in the right middle lobe, which you can see clearly here and there. A right lower lobe pneumonia, again, you lose that diaphragm border. And so that's what we've lost here, that silhouette sign. Tuberculosis can cause consolidation. It can cause increased size of your lymph nodes. It can cause pleural effusion. Tuberculosis more commonly involves the upper lobes. Pulmonary hemorrhage. So when you're bleeding into your lungs, the airways are filling. And so you can see opacity with air bronchograms. Gosh, this is not real clear on my screen, but we're looking at this upper area here, and you can see these air bronchograms, the dark gray airways that are still visible. Pulmonary embolism is a blood clot in the vasculature. Usually you don't see any evidence of this on the chest x-ray. The reason we get chest x-rays in patients that we think have blood clots is to rule out other causes of shortness of breath or low oxygen. Now, there is an exception to that, and that is a Hampton's hump, which is a rounded opacity where there has been decreased perfusion and ventilation, and then subsequent decreased ventilation. And that's what this is here. It's like an infarct in the lung, and that's what this area is here. This is really obvious. I don't think I've ever seen one that's that obvious in person. Here is a picture of a pulmonary embolism, and so normally the vasculature should be nice and bright white, and you can see over here that there is a blood clot here. You can see there is a blood clot right here as well. Moving on to pleural effusion. Common causes of pleural effusion can be congestive heart failure, infection, trauma, pulmonary embolism, cancer, renal failure. With that, the fluid tends to settle to the bottom of the lungs, and so you can lose your costophrenic angle. And so you can see normally, you can see an angle right here where it's black, and right here you can see there's fluid sitting in this angle. Same thing back here, you can see that there's fluid sitting here. This shows pleural fluid, this gray, and this is an abscess. There's some type of lung process here. Pneumothorax, we're really running low on time, I apologize. The pneumothorax is air inside the thoracic cavity but outside of the lung. So it appears as the same density as the air in the lungs, but there's no lung markings there. And so you can see in this slide here, this little sliver of black is a pneumothorax. You can see the pleura of the lung, which is this little white line here. When patients are sitting upright, that air is going to travel upwards. So you can see it at the top of the lung. If the patient's laying flat, it's more difficult to see. This is a tension pneumothorax, and so this a little bit more clearly defines what I mean by no lung markings. So you can see that there's lung markings here and here, and this is a giant pneumothorax here. There's no lung markings. You don't see any vasculature. You don't see any lung tissue there in the x-ray. Here is a pneumothorax right along the mediastinum, and you can see the sliver here with no lung markings. And then one of the other things you can see is that you get this deep sulcus sign, which is the outline of the diaphragm extends a little bit deeper than what it normally is. And that's another clue that there may be a pneumothorax. A hydropneumothorax is fluid that also fills that space. And so again, if patients are sitting upright with gravity, that fluid will go to the bottom. And so you can see a line of fluid here. You can see a straight line of fluid going across here in the lung space. If you tip them on their side, that's going to layer down to the bottom. It follows gravity. And so you can see that line of fluid here. Pulmonary fibrosis is a scarring or a stiffening of the lungs. These patients have shortness of breath, non-productive cough. They lose volume in both lungs, and you can see linear opacities in both lungs. Emphysema, these patients lose their elastic recoil and have destruction of their pulmonary capillaries, generally caused by cigarette smoking. So they have hyperinflation, they have very big lungs. They have increased space behind their sternum, which is what you see here. You see this big open space directly behind the sternum. And then flattening of their diaphragm. So instead of having a nice hump on their diaphragms, they're sort of flattened. They can also have bulla. Sometimes these patients need 2 x-rays just to get their lungs in, to be able to see both the top and the bottom of their lung because their lungs are so elongated. Rib fractures, you know, you're gonna lose this nice smooth contour of the rib, and you can see over here, there's a fracture here and a fracture here. And so you don't have the nice smooth line, you have an abrupt break in the ribs. I don't know exactly where I'm at on here, but there's a lot more to go. So in the interest of time, I think we can probably start here, and I can always pick it up again later, but these slides will be available. And I'm happy to stay on and answer any questions that anybody may have.
Thank you so much, Dr. Sela. We can certainly work to reschedule you for the second half of today's presentation as well, and that way everyone can listen to your presentation again to finish this. But like you said, we will attach Dr. Sela's PowerPoint in the recap email today, so you all will have a copy of her slide deck as well if you wanted to see that. We are at the end of the hour, so I just wanted to thank both Dr. Doyle and Lisa for the case, Dr. Sela for the great presentation. Our only announcement today is that our next session will be on March 15th, and Dr. Sharma is presenting on electronic vaping induced lung injury. So keep an eye out for that email reminder, and we'll see you all next time. Thank you, guys.
Thank you.